Thank you, sir. I would like to invite Nitin Burkule, sir, for giving us a talk on uh, MINOCA evaluation.
Can you give me the presenter view? Presenter view. Give me the presenter view. Presenter. Yeah. Yeah, respected chairpersons and my dear friends, MINOCA is actually not very rare in our practice, and I will show you some rapid cases. Uh, as we know that by definition, it has to be a clinical MI with a normal CAG or a non-obstructive coronary disease, and you have to rule out a non-ischemic cause for troponin leak. So there the multimodality imaging is so important. So we'll look at this case, a 55-year-old gentleman, hypertrophic cardiomyopathy with atrial fibrillation. He had giddiness and severe chest pain when he was jumping on the railway track. ECG, no fresh changes. Troponin was elevated. And this is his ECG, obviously AFib with a pattern of an HCM. And obviously on the echo, you won't find any regional wall motion abnormality because it's a very severe LVH. And this is his angio. You don't see any obstructive coronary artery disease here. And this is his cardiac MRI, which also shows the typical pattern of a hypertrophic cardiomyopathy. But if we look at the T2 maps are for looking at the edema, you can see that there is a very significant edema at the, I'll just have the pointer here. Yeah. There is a significant edema here at the lateral wall. Okay. So definitely there is a circumflex territory injury because MRI has got this memory of injury and retaining the edema, and this is a late gadolinium enhancement, and you can see that there is a transmural infarct here in the circumflex territory, and what black thing you are seeing inside this white is a microvascular obstruction. So he definitely has a circumflex territory infarct. You don't have anything on the angio, so either it's an embolic because he had an atrial fibrillation and he was on very small dose of rivaroxaban. Let us look at this second case, a 58-year-old male, a hypertensive diabetic non-smoker. He had rest angina for almost 3 hours with a normal ECG and a troponin in 2000 picogram per ml. This is the ECG except for a T inversion, there is nothing there. And this is his angio, and doesn't show any obstructive coronary artery disease here. And we have this right coronary here. And then the coronary, the echo doesn't show any regional wall motion abnormality. The MRI also doesn't show any regional wall motion abnormality. But let us look at this T1 maps, and you can see this white area here and the basal slice, which is showing you a very significant transmural edema here. So that means that's something, an OM territory there. And if you look at the T2 map again, you can see edema at the OM territory. And let us look at the late gadolinium enhancement. You can see that there is a transmural infarct here, which is actually extending into the papillary muscle also. So let us look at the angio very carefully. I think now you can point out a stump of a small OM branch there. I think everyone can see that there is definitely a stump there of the OM. So this is actually not a MINOCA. This is a true occluded coronary artery which we have missed. Let us look at the third case, a 70-year-old gentleman, acute chest pain and rise in troponin to 3000, echo mild global hypokinesia, and this is his ECG, mild ST depression in lead 2, 3 AVF, and this is his angio. Of course, for a 70-year-old man, this is a non-obstructive coronary artery disease, few plaques here and there, some disease in the PDA ostium for sure. And this is his echo, which shows global hypokinesia, and the hypokinesia is not restricted to any coronary artery territories. The common viruses and their titer was negative. And this is his MRI, again showing a very showing some reduced ejection fraction, but more the akinesia is at the basal septum. And we go down to the late gadolinium enhancement, and you can see that there are significant focal gadolinium in the basal septum, very focal in the basal septum. And you can see also in the long axis, you can see the basal. So these are the granulomas at the basal septum. But and if you look at the again the edema map, you can see the edema in the basal septum here, and then we subjected him for the PET, and you can see that once the moment we come into the there are no lymph nodes in the mediastinum, but see the myocardium, and you will see that you will appreciate that the myocardium is studded with so many granulomas which are extremely active. So our problem was whether it is a sarcoid, cardiac sarcoid versus a GCM, that is the giant cell myocarditis. Patient refused the biopsy, but we put him on steroids and then azathioprine, and you can see that this is within 6 months, entire thing is vanished. You have no activity in the myocardium as compared to what it was in December. And the I mean, the literature also tells you that the pattern of this involvement in the basal septum are common both with the cardiac sarcoid and the giant cell myocarditis, because they are a continuum of T cell mediated inflammatory cardiomyopathies. A 32-year-old lady, non-hypertensive, non-diabetic, no history of premature IHD in the family. She's a PCOD, hypothyroid, taken OC only for 1 year. She had an angina of effort in 2019. ECG was normal, so it was neglected. 2020, she had an uneventful pregnancy. But in 2022, she again started getting severe angina, especially postprandial, even sometimes at rest, relieved by burping 2-3 times. Again, it was neglected. She had a severe rest angina last July, and she was admitted with troponins of 21,000 and was treated with aspirin, ticagrelor, and statins. And this was her ECG, which showed a QS pattern V1 to V3. Okay, she's a young lady, 32-year-old. And this was her angio. This was a right coronary, which looks fine. Left coronary, you have a ring-like plaque in the circumflex. And if we look at the LAD also, there is some ring-like plaque after the diagonal, but these are definitely non-obstructive ones. And she again had a recurrent pain in last December, admitted with troponins of 24,000. She was put on, now added a rivaroxaban to that, and again in 2 days she again had a severe chest pain. Here you have got some ST depression, V4, V5, 1 AVL, and this is his angio. There appears to be some another ring-like plaque in the RCA, non-obstructive one, and the plaques in the circumflex and circumflex and the LAD look the same. And we look at the echo, and you can see that there is a significant dilated LV and regional wall motions at the apex and also in the lateral wall. Investigations, lipids are fine, lipoprotein A is high, connective tissue disease profile is normal, ANA, ANCA, everything is normal. The lupus anticoagulation is negative, thrombophilia profile is negative. The MRI shows you the same thing, a dilated LV with regional wall, both in the LAD and the lateral wall. And this is the T2 map, which again shows edema in the septum. If you go ahead and look at the T1 map after giving gadolinium, you can see a large subendocardium gadolinium retenment in the LAD territory also and in the circumflex territory also. And you go ahead into the short axis and you can see here transmural infarct both in the circumflex and the LAD territory. So over the 3 years she has she's a true MINOCA. And where the intravascular imaging is so important, because one may pick up plaque rupture or erosion or a in situ thrombosis or a SCAD or even a epicardial coronary challenge you should be doing in these patients. So here the MRI tells you which vessels to look for, because we know they infarcted in the LAD and the circumflex. That means those plaques are active. So we may be looking for all these pathologies which are not picked up by our regular coronary luminogram. This is a 67-year-old lady, chest pain, syncope after son's death, troponin, typical scenario, troponins 0.14, ECG, T inversions globally. But you look at the echo, which is very interesting, that you can see that there is no apical ballooning. The apex is contracting well, base is contracting well, but the equator of the LV is not contracting. Look, it is much more appreciated in the MRI also. You can see the apex is contracting, the base is contracting, but the equator of the LV is not contracting. It's a very interesting pattern you see, and this is her T2 edema image, and you can see that the mid septum and the mid lateral wall are having edema. So this is the equatorial distribution of the sympathetic nervous system, and typically they don't have any late gadolinium enhancement. Okay, this is a very typical Takotsubo. And lastly, I'll go through a very interesting one, a 35-year-old male. He had a past history of DVT on rivaroxaban 10 milligram. He had chest pain on and off for 2 days, increased severity in the night, so came to the casualty, troponin 1000, and then it reduced later on. HSCRP was slightly raised, ESR was normal, and this is his ECG, and one can see that there is a ST elevation in 3 AVF. So we went by a PAMI pathway, thinking that this is a evolving inferior wall MI, and this was his angio, perfectly normal. The left system is perfectly normal, the right system is perfectly normal. Many cardiologists will lose interest here, but let us go ahead. And this is his echo here, and you can see that there is a very little inferior wall akinesia, very little inferior wall akinesia. But look at the MRI T2 images, multiple areas of edema here. Okay, they are there in the inferior wall, in the posterolateral wall, at the apex, so and so forth. So many places of edema there. So also on the T1 maps. If you look at the MRI, you will see multiple areas of late gadolinium enhancement which are subendocardial or sometimes transmural, and you can see that multiple of them, and sometimes in between you are having an area of microvascular obstruction. So this is a shower of emboli. This is a shower of emboli into the circum. So where is it coming from? So his investigation shows D dimer of 1.59, which is high. Homocysteine was okay. He was APLA strongly positive, anticardiolipin strongly positive, ANA positive, and also he had an autoimmune hemolytic anemia. And actually he was already had a past history of DVT when a topmost hematologist has already diagnosed APLA and asked him to be on anticoagulation, but he stopped warfarin and shifted on to rivaroxaban. And so then the thing is, you have to know from, because they have to be on the venous side, they have to come to the coronaries. So first you look for non-bacterial thrombotic endocarditis, so T not showing any NBT, and then you do the look at the PFO, and then you give saline bubble contrast and do the Valsalva, and you can see that there is a shower of bubbles which are coming through the PFO. So that may be the reason that he had from the venous side, he had showered to the systemic side across the PFO and must have got so many emboli into the coronary. So we put him on the warfarin, and last 1 year is fine. So arch is all fine. So how do you evaluate the MINOCA? First you have to show rise and fall in troponins. And coronary angio where no obstructive disease or less than 50% obstruction, and then look at the clinical context. There should not be pulmonary embolism, sepsis, hypertensive crisis, tachycardia, arrhythmias, cardiac contusion, anemia, so that because those are the ones which can explain troponin leak. So that is not a MINOCA. Then again go back to the coronary angio and look for an occluded artery. You may have a flush occlusion of some of the branch because you never knew his angio before, and if it is that, then that's an occluded coronary artery. Just the last slide. And then you look at the echo and MRI very carefully, and then you would probably will find a non-ischemic cause of a MINOCA, which may be a Takotsubo, myocarditis, sarcoid, infiltrative cardiomyopathies. These are all MINOCA mimickers. They are not actually true MINOCAs, but presenting exactly like MINOCA. And then you look at the subendocardial LG, which will tell you that definitely there is a coronary insult. And then you know the target vessel to look for the IVS or the OCT. If they are also normal, then actually you will have to look at the microvascular function by acetylcholine challenge, looking at the FFRs and the intramyocardial resistance. Despite that, you will have 15% of patients where you will not find anything, and that these are called as unclassified MINOCAs. I think I'll stop here. Thank you.